So my name is Sepideh Amin-Hanjani. I'm the immediate past chair of the Stroke Council. It's my real pleasure to have the opportunity to speak with the lead investigator on the CHOICE-2 trial, Dr. Chamorro. Welcome, Dr. Chamorro.
Thank you. Thank you very much. My pleasure to be here.
So it would be great if you could just give us a brief recap of the main premise and results of the CHOICE-2 trial.
Yeah, the CHOICE-2 trial basically what it tries to do is to demonstrate that the infusion of a thrombolytic in a patient that has resolved apparently the problem with the thrombectomy is still beneficial, because it does not believe that the angiography is a reliable technique to tell us how the microcirculation is. So we want to get rid of the large thrombus first with the mechanical device, and then infuse a thrombolytic agent distally to lyse all these microthrombi that we expect to be present in a significant proportion of the patients that are treated with mechanical thrombectomy.
Tell us a little bit about how the initial CHOICE trial informed the design of this study and why you felt it was necessary to do CHOICE-2.
Yeah, well, the CHOICE-2 and the CHOICE-1 trials are basically similar, with some differences that were forced by the situation. CHOICE-1 compared, which is very unusual in thrombectomy trials, was a double-blind. There was the infusion of a placebo, intraarterial infusion of a placebo, to compare that with the infusion of a thrombolytic. The problem was that was the time of the pandemic, and the recruitment rate was not that good. There was many difficulties to perform the clinical practice in the hospitals. And we ran out of the placebo. The shelf life of the placebo ran out, and the manufacturer of the drug and the placebo could not stop the machinery to manufacture placebo. So we were forced to stop the trial when only the 60% of the study population had been enrolled. Nevertheless, the effect was so huge, 18.4% absolute difference in the primary outcome, the proportion of patients with a ranking 0 to 1, that the study was marginally positive with a p-value of 0.04. So of course, when we published this, we had to accept that these were preliminary findings. So we need to replicate this. And that's why we plan and design the CHOICE-2 trial.
Tell us a little bit about the selection criteria in CHOICE-2. Which patients were you actually including within the trial, at what time frames, and which angiographic outcomes were eligible for it?
Yes, well, we tried to be very pragmatical. The funding we had tried to incorporate a trial that reflects more or less what real life is at tertiary stroke centers in the country. Although I have to say that this practice is quite similar across countries. Another story will be to discuss secondary prevention measures or primary prevention measures. But if we talk about high tech, it doesn't matter really if we are in Spain, in Germany, in Alabama, or in Wisconsin. It's very similar. Similar guidelines, similar expertise, similar technology. So I think this is very comparable. So we try to get as many patients as possible. And which are the patients that we needed? Those who now the guidelines accept as successfully treated. So that you have enough information to stop the therapy. And currently, when you treat a patient with mechanical thrombectomy and you get a TICI score of 2B, means that you have at least 50% of the previously ischemic territory reperfused, and this is considered successful in all the clinical trials performed so far in thrombectomy. So we think this was a referral or a starting point. Let's take those patients that interventionalists consider they have finished the job, and this is the patients that we want to treat and demonstrate that you should not realize your eyes when evaluated as cerebral angiography, because it's not able to pick up Most of the circulation is in the brain, which is in the microcirculation, not in the large leptomeningeal vessels. And this is exactly what CHOICE and CHOICE-2 is challenging.
Yeah. And I think it was interesting that you included some imaging parameters in your secondary outcomes that help kind of support this thesis that it's really a perfusion improvement that's occurring.
When you want to change practice, you have to be pretty much aware that you will find a lot of skepticism. People will be very reluctant to accept what? I have to finish a patient with a thrombectomy, normalize the angiography, and still going on with a thrombolytic agent. They will be reluctant unless you show them data. No hypothesis or idea, but data. So what is the goal of infusing a thrombolytic agent in a patient with a normal angiography? To find thrombi and open it up. How to demonstrate this? Angiography is useless. You cannot demonstrate whether the microcirculation reperfused, because this is one of the bases of the trial. Angiography, you should not rely on angiography. So you need to do something else. What? Perfusion imaging. Advanced perfusion imaging. The most conventional technique used in clinical practice across the world, I think, is CT perfusion rather than MR. So we decided to incorporate and make it obligatory to do a CT perfusion to all the patients randomized and include the prevalence of a normal perfusion in the protocol to all patients included in the trial.
Okay. Yeah, no, I think that was a very helpful mechanistic basis to prove as well. Now, looking at the results, you obviously saw a remarkably good improvement in the MRS 0-1. On the counter side, there was this increase in mortality. Can you talk a little bit more about that and what you think is going on there?
Yeah, well, if you take altogether all the contemporary trials on thrombectomy in patients that on admission they have a successful thrombectomy, and there are a couple of meta-analyses published in the last year, including 6 clinical trials, or trial in Spain and 5 Chinese trial. The numbers you have to remember is that the proportion of patients dying in these trials is 18%. 18%, both in the active group or in the placebo group or the control group. So there's more than 2,000 patients already treated in those trials, showing clear no signals on mortality. And numbers ranging from, as I said, 18% on average. We found a 6%, 3 times lower mortality rate in the control group and a 12% in the active group. So both groups show very low mortality rates, but if you compare the relative difference between the two, it was a significant difference. But you have to take the whole picture in order to understand, because it's quite clear that we can say that the therapy does not increase mortality. Only 1 patient among 440 had a bleeding that the central committee thought associated to the therapy. 1 out of 440. Only 1 death. And the rest of the deaths were those that you expected in patients with large vessel occlusion. Stroke-associated pneumonia, progressing stroke in a group of patients, and quite similar numbers in the 2 groups. Most of the deaths occur after the first week of the therapy, a therapy that is in your blood for 8 minutes. So we think that the mortality difference reflect baseline differences in the characteristics of the patients at baseline.
Yeah, and I think you had noted that the treated group was a slightly older group than the control group. Yeah.
The 26 patients that die in the active group were 4 years older than the 14 patients that die in the control. So 4 years, when you are 75 or you are 80, is a major difference. And this is probably one of the contributors to the higher mortality found in the active group.
Okay. And finally, can you comment a little bit on why you think your trial and the way it was designed led to a favorable outcome as compared to other recent trials that have not shown a benefit from intraarterial thrombolysis, although not necessarily with alteplase and not necessarily the exact same design?
Well, we shouldn't we should remember one of the most intelligent phrases we coin in the field of stroke. Stroke is brain. Time is brain. Our trial, patients are treated, the drug is infused approximately at 4 hours from the onset of symptoms. In the other trials, most of the trials, the drug is started within 7 or 8 hours after the onset of symptoms. I think this 4 hours difference between those trials make large part of the difference.
All right. All right. Well, congratulations on presenting these results. Thank you very much for being with us here at ISC.
My pleasure. It was my pleasure.